Hi, I'm Jessica Oakes, and I am thrilled to give a talk today at this conference, and I welcome any questions that arise during my talk. So today I'm going to discuss a way to better classify uncontrolled asthma using image-guided computational models. Uncontrolled asthma is defined as having poor ventilation, gas trapping, and often mucus plugs that lead to severe asthma. Uncontrolled means that it's difficult to treat and patients have disease progression that occurs throughout their lifespan. Here I'm showing three images of ventilation, ventilation where the teal is where the inhaled gas is going. And as you can see, as the asthma severity increases, you have more and more black regions, meaning more and more ventilation defects. Subjects in particular with mucus plugs do not respond well to bronchodilators. So this here is showing you a test where a subject used a bronchodilator and before and after did a spirometry test. Spirometry here is measuring FEV1, so it's the amount of volume exhaled in 1 second, and this is through forced maneuver. So pre and post bronchodilator, the subjects that had little to no mucus plugs had good response to the bronchodilator, where subjects with high mucus plugs or high number of airways that are plugged didn't respond very well to the bronchodilator based off this FEV1 measure. So our group works with Professor Sean Fain at University of Iowa to integrate medical imaging data into computational models of the airways. And so we leverage data that his group collects, specifically CT data and MRI data. The CT data we use to generate the models, and the MRI data we utilize to look at the ventilation defects. So the larger the ventilation defects, the larger the number that we're given. So these ventilation defects can be prescribed for various regions of the lung, and that's what we call this SVDP. And it's basically a percentage of the volume that has a defect. In this study, we're looking at 26 subjects that are evenly distributed between mild, moderate, and severe asthma. We have clinical measures. We have a whole database of measures that are taken on these subjects, but the ones that we're honing in on are these clinical measures of spirometry, FEV1, and FVC, as well as a history of exacerbation, as well as need to go to the hospital. As I had mentioned before, severe asthmatics have substantial regions of the lung that do not receive inhaled gas, and we can classify this based off the defect level. So here I have defect levels of VDR, LVR, MVR, and HVR. VDR and LVR are the defected regions, and the other two are regions that are not defected. M is moderate and S is severe. So as you can see here, the subjects with severe asthma have higher levels, higher regions of ventilation defects compared to the mild moderate. So we utilize this information in our computational models. So as I mentioned before, we leverage the CT data to build the 3D geometry, and we leverage the MRI to prescribe boundary conditions. So once we have the 3D models and we run the simulations, we're interested in the gas distribution at these distal airways. And this is because we can't measure it in vivo. So we're leveraging the ventilation defects in order to prescribe these resistances. We iterate on the resistances until we get the ventilation defects that are measured in the clinic. Once we run the simulations, then we're interested in output parameters, including the distribution of gas, airway resistances, as well as particle deposition. My PhD student, Cameron, is the one that performed these simulations and should be celebrated for this work. So first, before I go into the data for the 26 subjects, I wanted to hone in on 6 subjects that we initially simulated. So here we looked at 2 healthy, 2 mild, moderate, and 2 severe subjects. The healthy subjects had relatively the same 3D resistances as well as negligible SVDP. However, as we look more at these subjects with asthma, and specifically these 2 severe subjects, their 3D resistances are quite different. They're order of magnitude different. While their SVDPs are relatively the same. Next, we looked at the deposition within these 6 subjects. And we noticed that for, again, these 2 severe subjects with similar SVDPs, AS4 had substantially larger amount of deposition in their central airways compared to AS3. And looking at these subjects, there does seem to be a big difference in their central airways. AS3's airways almost looked a bit more ballooned, while AS4's airways were highly remodeled and irregular in their shape. So this made us go deeper into these different types of asthma phenotypes. So the first thing we looked at is the clinical measure that's done. This measure is done to help diagnose asthma as well as look at the progression of asthma. And we see for our severe and mild moderate, there really isn't any different in FEV1, even though this is the measure that's used routinely and in the clinic. So then we looked at the computational endpoints. And the first endpoint that we looked at is a 3D resistance. So this is the resistance in the model that we're simulating. And we see that with our severe subjects, while there's a large variability in this 3D resistance, as I had demonstrated with the 6 subjects, this resistance in the central airways was significantly larger than the mild moderate subjects. Looking at total resistance, so this is the resistance of the distal airways plus the central airways. The total resistance also was higher in the severe subjects compared to the mild moderate. The next measure we looked at is a central deposition. Central deposition is the deposition within our central airways. The rest of the particles are exiting out our distal model to the distal regions of the lung. And we see again this increase in deposition in the severe airways compared to the mild moderate subjects. This may be good if you want to target the central airways, but it's going to be not great if you want to deliver drugs distally. And this is really looking at where the asthma remodeling is taking place. So the next measure that we looked at besides the severity level was the hospitalization. So these are subjects that have gone to the hospital within the past due to an exacerbation, an asthma-related exacerbation. And so we wanted to see if resistances and deposition did correlate with this need to go to the hospital for help. And we see that it does, that distal resistance as well as total resistance was higher in the subjects that needed hospitalization versus the subjects that did not. Note here, we do have a mix of mild, moderate, and severe subjects. So the triangles are severe subjects and the circles are mild, moderate. We also saw a similar correlation with central airway deposition. Central deposition and central resistance should be somewhat correlated, and this is because central resistance is related to the 4th power of the airway diameter, and deposition is going to occur for the same ventilation levels. It's going to be higher deposition for a smaller airway. So we wanted to look at this relationship for these subjects. This is a way to see if central deposition is correlated to central resistance and whether or not mucus plugs, the number of mucus plugs, impacts this relationship. As you can see, for subjects with high mucus plug, this subject particularly has 7 mucus plugs in their airways. They had very high central deposition and central resistance, much different than the average subjects. We also wanted to look at whether or not central deposition correlated with reversibility. And so this is FEV1 change, that spirometry measure, versus central deposition. And as you can see, more deposition, more FEV1 change. Here we're only looking at subjects that had a FEV1 change that was positive. There were some subjects that had a negative response to the bronchodilator, which is an interesting phenomenon that we haven't yet gotten a chance to study in depth. We also looked at VDP reversibility. So this is the reversibility of the MRI measure of defects. You can note that the subject here, the square subject, is a subject with several mucus plugs in their airways. And again, they do not tend to follow the trend that they have high central deposition, but their FEV1 doesn't change. So in conclusion, we found that airflow mechanics is correlated with severity levels in past hospitalization. And this is better correlated than the spirometry measures that are taken in the clinic. The regions of high deposited dose correlates with central airway remodeling, with the caveat of the subjects with the mucus plugs. And then the presence of mucus plugs does lead to high airway resistances and particle deposition. As we continue on with this effort, we would like to look at subjects prospectively. So this was a retrospective study. We were interested in including collateral ventilation. So this is looking at the gas redistribution in the lungs throughout the breath. And this is due to different time constants or regional time constants of resistance and compliance. We're also very much interested in response to inhaled medication. So as I mentioned, this is a retrospective study. So doing a study where we try different types of inhaled medications or biologics to see if the airways reverse, especially in these uncontrolled asthmatic subjects. And with that, I would like to thank you for your attention. And I would specifically like to thank Sean Fain for providing us modelers with great imaging data and for his expertise in asthma. And again, I would like to thank Carmon for his wonderful work. Thank you.